talk a little bit about sexual assault exams, our forensic exams, because as you know at Mercy, we've also included additional services for La Plata County and the Four Corners region. So we're going to talk a little bit about what an FNE is, a forensic nurse examiner, and our process. So goals of this presentation is so that you understand what the critical role of the FNE is and the financial, physical, and emotional impacts that happen to the patients who are a victim of violence. So what is a forensic nurse examiner? Here's the long version of it. You can read it yourself. Basically, it's a nurse or an advanced practice nurse who's had additional training to care of victims of violence. It meets the evidentiary needs of these patients. So if the patient is requesting evidence collection, we can also assist them with that. And it also allows us to go into the courtroom and do testimony based on our opinions from the exam and our head-to-toe assessment that we see. If we see any injuries, or we can speak to any biological DNA that was discovered during the analyzation process. Additionally, we care for the needs of the patient on the medical side as well. So if there's any injury, we can help attend to those in addition to the evidence collection. We receive 64 hours of didactic training in addition to our board certification as a registered nurse. We have 2 days of clinical skills labs that we complete in Colorado Springs. And that is a hands-on training. We learn how to collect evidence, talk to the patient, what the reporting options are in the state of Colorado, and that way we can kind of verbalize that to the patient, explain to them, help them make that decision. We also do forensic photography practice in those clinical skills and learn how to do a head-to-toe assessment, focusing specifically on these forensic patients. At Mercy, I also require that the new forensic nurses complete a 3 12-hour clinical preceptorship at UC Health at Memorial in Colorado Springs. Memorial hosts the Colorado SANE Safe Project, which is a statewide grant that trains forensic nurses. In this way, they can work side by side, maybe even with some instructors from the SANE Safe Project. But this program sees over 2,200 victims of violence a year. So the nurses are exposed to a pretty wide range of violence, in addition to it all being compressed down in 3 12-hour shifts. At Mercy, once they complete their 2-day clinical skills lab and they do their 3-day 12-hour shifts at Memorial, we rely on the nurses to tell us how much more orientation they need at Mercy to learn what our practices are. Depending on what the patient loads are, if we have a high volume, typically they're off of orientation faster than if we were to have a low volume. Sometimes the nurses can stay on orientation at Mercy for up to 3 months, sometimes 4 months, depending on where their needs are. And with all of this, all of us continue to do continuing education throughout the year, either, doing webinars or watching symposiums like this one so that we can stay abreast to the new evidence research, and also so that we can stay connected with our community needs as well. So as I was saying, for the role of the forensic nurse and what our exam encompasses is we do the complete medical screening exam. So the patient walks into the ER and we're notified by the tech. We arrive to the ER and we screen that patient for any acute injuries that they might have, meaning that if they have any bleeding or anything that warrants getting a doctor involved, then we'll go ahead and get that doctor to come in and do an assessment and make sure that that patient is medically stable. If they are saying that they're suicidal at the time that they come in for their exam, then what we want to do is make sure that we get Access involved as well. Access is our mental health provider at Mercy, and they'll come in, do an assessment on the patient, and determine what the plan of care would need to be depending on how that patient is presenting. Some of the reporting options that the patient has is they can report to law enforcement, do a full law enforcement report, meaning that they talk to law enforcement, they have evidence collected, and they're choosing to have that evidence analyzed as well. So we would do a head-to-toe exam. If they're within evidence collection window, we would collect evidence. And then the second option that they have is they can do a medical report, meaning that they don't want to talk to law enforcement, but they do want a medical forensic exam. So we would continue to provide all the medical care that we can offer them. Maybe they do want evidence collected. So if they would like evidence collected, we can collect it and we can have law enforcement store it for up to 2 years. And then if they change their mind and they would like to have that evidence analyzed, they sure can. The last reporting option is Senate Bill 128 that was passed a few years ago, well, several years ago. And that is the anonymous report. So the patients have to be between the ages of 18 and 69 in order to qualify for this anonymous report. We can collect evidence, but we cannot analyze it because we don't have a name to attach to that evidence when we send it off to the crime lab. So they would have to provide their name. Sometimes patients just need a little bit more time to kind of process what happened to determine if they want to move forward or not. But we are able to still capture that evidence at the time that they present at the hospital, if they're within that evidence collection window, and we can store it for them. So if they change their mind, we can move forward with that process. We complete a head to toe exam, just like your well woman's exam or, your annual exam for the guys out there. It's a head to toe. We listen to heart, lungs. We look at the eyes. We palpate the belly. We look at all extremities for any injury, and then we're documenting all these things as we're doing our head to toe exam. If they like forensic photography, if that's something that they consent to, we're taking photos as we're doing this exam as well. And that photo documentation is used as evidence if it goes to court. Typically, the only people that are going to see that is going to be the defense, the prosecutor, the judge, and the jury, if that is something that they submit into evidence. We store that on a very secure drive that only the nurses have access to. So that's not something that's floating around out there. It's very secure when we store those photos. We can also do a pelvic exam for men and women. The pelvic exam looks a little bit different for men. It's a speculum exam. And if you see that picture that I included on this slide, the bottom right, there's like a little thing in plastic that has a green handle. That's a speculum exam. And so that helps us visualize the internal structures of the vagina, the vaginal wall, the cervix, to look for any injury, also to collect evidence if there was penetration and warrants evidence collection there, if the patient chooses to have evidence collected. And then you can see all the swabs that we collect, our little swab dryer. And then sometimes, depending on if, where we're collecting, if it's oral, vaginal, anal, or cervical, we have to set up a little slide. And those are those little black slides that you see with a clear window in the center. So we just kind of dab a little bit on that slide. And what the crime lab is looking for specifically on those slides is semen. And then anytime we collect outside of those areas, we have to notate what it is that the crime lab should be testing for. They use different reagents for the things that they test for. So it's important to us as the forensic nurses to include that information, like he touched me here, he sucked on me there, he put his hands on me here, so that they know what they're looking for. And it saves them time, and it makes their process a lot more efficient. On the top of our exam table, what you see in that blue plastic package, that's a Foley, and we insert that into the vagina. We inflate it, and then we're looking at the edges of the hymen to make sure that we don't see any injury. It really helps kind of open up the hymen. The hymen on an estrogenized woman, the hymen's kind of like a hair scrunchie. So this balloon helps inflate that little hair scrunchie, or open up that little hair scrunchie, so that we can see all the edges to make sure that there's no injury. Now, we would not do a speculum exam or a Foley on any patient who's not had their period or their menses. So it's only for post-pubescent patients, not pre-pubescent patients. You'll also note that, and I'll kind of show you here, right there, this is a little tool that we use. It's called Toolating Blue. And it's a little dye stick that we pop, and we can put it on areas of the skin that might look like there's injury, but we're not 100% sure. And whenever we put that on the skin, we can wipe it away with a little 4x4 and a little saline. And if the entire dye wipes up on our cotton 4x4 swab, then that means that there was no injury. But if there is some residue that stays back on that area where we thought maybe there would be injury, there would be uptake. And so that would tell us that there in fact was skin breakdown, because it will only uptake if there was skin breakdown or injury, an abrasion, a laceration or something. And then that way we can note that there was in fact injury in that area that we suspected, but it was really hard for us to see with our own eyes. So it's just an additional tool that we'll sometimes use. You'll also note there's a whole box of gloves on our table. That's because we have to practice that we don't cross-contaminate whenever we're collecting this evidence. So we take off our gloves and replace them in between every site that we collect to make sure that there's no cross-contamination. We all have our hair pulled up whenever we're doing these exams to make sure that we do not leave any evidence of our own on this table. And then right here is our little swab dryer. So these are our swabs. After we collect the swabs, we can then place them on the swab dryer, and these are all labeled where we collected the evidence. And then this swab dryer container here actually goes in the actual swab dryer device, has a door, we shut the door, and it dries for about 30 minutes, 20 to 30 minutes. And typically that's plenty of time for us to go ahead and package all of these swabs in these envelopes. Once those envelopes are sealed off with evidence tape, we sign across the top of it. We put a patient sticker on the front, and we put our initials because we're the ones that collect it. And then they all go into this bigger envelope that we seal off with evidence tape as well. And we hand that off to law enforcement. Law enforcement will then sign the outside of it for the chain of custody. And then they send it off to the crime lab if the patient is choosing to have it analyzed, or they store it if the patient did not choose to have that evidence analyzed. Now, I want you to know that even though the patient may have consented to forensic photography, evidence collection, a speculum exam, that doesn't necessarily mean that's what we're going to do through the exam. We always check in with our patients. We want to make sure that this is something that they still are comfortable with and they're still consenting to. It is 100% patient driven. We do not want to re-traumatize our patients during our exam. So we want to make sure that they're comfortable with the process, because it's not our goal to complete all this evidence collection. Our goal for our patients is to make sure that they're safe and make sure that they're healthy and make sure that they have the resources they need to continue on and through their healing journey, and make sure that they're safe. We also provide STI prophylaxis, and what that is also known as STDs, but the CDC calls it an infection and not a disease because it can be treated. So we treat for gonorrhea, chlamydia, and syphilis at the program. Gonorrhea, chlamydia, and trich. We can treat for syphilis, but it's not as common. We also offer post-exposure prophylaxis for HIV. We will go over the risk factors with the patient, depending on what their risk factors are, that we might talk to them about this prophylaxis. We have a very low prevalence of HIV in Durango and the Four Corners area. So it's something that we want to make sure that the patient is going to be able to commit to also, because this is a long process. It's not a one-time dose like the other medications. It's a 28-day regimen. And we also offer emergency contraception, which is Plan B at Mercy. And then, of course, we go over discharge and safety planning. And if any of you saw the safety planning presentation, that's pretty much it in a nutshell. So we talked about the chain of custody, and testifying is something that we have to do if it goes to trial. If we were the nurse that took care of that patient, what that looks like is we are sometimes, they will slot us as an expert witness if they determine that, sorry, the cat's in the background now. If they determine that we can qualify as an expert witness, most of the time we are qualified. And, only about 3% of our patients are actually going to go to trial, which is too bad, but they have to prove it without a doubt that they will potentially get a conviction. So not many of us have to go to trial, but if we are called in, we do testify. We contact DHS, our CPS, if it is a kiddo 17 and or under, depending on the circumstances, and then Adult Protective Services if they're over the age of 69. And then we also, of course, will call law enforcement, make a report if a report hasn't already been made. And then during our exam, if we notice any serious bodily injury, and what that encompasses is broken bones, loss or bowel or bladder function, loss of consciousness, burns of the second degree, gunshot wounds, and typically for us, it would be loss of consciousness or loss of bowel or bladder function. We're going to fill out that form and we're going to submit it over to law enforcement so that we can file an SBI against that perpetrator. At Mercy, we're now seeing strangulation patients, and Judy did a great job talking about strangulation, so I'm not going to go into that, but that is a service that we do offer at Mercy now. And we also will talk to our patients about stalking. And then we also provide any follow-up medical care information that we would recommend for them based off of our assessment referrals, psychosocial needs, community resources. These exams can take a long time, anywhere between 4 and 6 hours with us, direct contact with the patient. And then the nurses typically stay for another 2 hours charting, packaging up evidence, and handing off that evidence to law enforcement. Patients will never pay for evidence collection of this exam. We bill law enforcement and the Department of Criminal Justice for evidence collection, so the patients will never receive a bill on that. So what are our limitations? Our limitations is we cannot definitively say if that patient was raped. CBI can do an analysis and determine whether or not there was biological DNA on that patient that does not belong to them. And they also have a server that lists all felony-related crimes and the people's DNA who committed those crimes in that server. Not all of them. They have to have their DNA uploaded, but it is felony committed crimes DNA in that server. And then we also cannot date injury. So we can't look at a bruise and say that definitely happened last night during her exam. There's just no way for us to date any injuries. Even if it was a laceration or abrasion, we can't do that. And we can't conclusively say that a patient was raped, even though whenever we go to trial, that is the one thing that the judges and the jury, they want us to say that, but we can't be an objective witness if we're saying those kind of things. Now, I want to talk just briefly about the neurobiology of trauma and why it's important. Dr. Campbell studied the neurobiology of trauma, and one thing that she says in the, how the patient presents, because it could be in an array of different presentations. They could be distressed, they could cry, laugh, self-blame. I've had patients laughing in the exam room before, and I know that sometimes that's just how patients, kind of process the trauma that they've been through. But it's hard for people to understand that if they haven't studied the neurobiology of trauma. It's also important to know that maybe sometimes they'll give us their history, but they're missing big pieces, or their pieces aren't coming together in order, or they're telling me something and then maybe I ask them a question about a smell or a touch and it triggers another memory. So Dr. Campbell does a great job of explaining how, if you were to take Post-it notes and throw them up in the air and they land, they would never land in the order that you would want them to. Just like that patient's memory who's trying to process this trauma, sometimes their memory just does not line up in order. It's their brain's way of protecting the trauma that they've endured. And so we have to be patient with them and understand that sometimes they might tell us something a little differently than they've told other people, but it's just the way the brain works. There's a lot of mental and physical and financial concerns for these patients who experience a violent act, specifically for for child and adolescent survivors. So if someone was sexually assaulted or abused in any way as a kiddo, they're 3 times more likely to experience depression, 6 times more likely to experience PTSD, whether that's, a place close by where it happened, or maybe it's a person who reminds them of, the person that raped them. These are all things that can trigger them through their lifetime. They're 13 times more likely to abuse alcohol, 26 more times likely to abuse drugs, 4 times more likely to contemplate suicide. These are our patients that are frequent flyers in the ER. I'd like to give you a little example. I had a patient recently in the ER. She was homeless, and yes, she was a meth user. She had a lot of things going on. She'd been in and out of the ER multiple times. They knew her, but she was there because she was strangled. Now, unfortunately, I'm getting a report from the provider, and, they come in with a bias because she is that frequent flyer, right? She's experienced so much trauma in her life. Learning about her history as a child, I'm adding up these ACE scores in my head, and I'll get into that here in a minute. So it's no wonder she's in this situation. I look back on her ER visits, which I commonly do with my patients, and I look at their medical history. And yes, she had been in the ER multiple times. So this provider is giving me a biased opinion about what's going on. And I listen, I go and I do my assessment, and then I come out and I am an advocate for this patient. And I say, I believe her. I believe these things have happened to her. I feel like this is the best way that we can care for her. I need diagnostic imaging. I need this, I need this, I need this. And you know what? They heard me. And I also took a moment to educate, about how these patients, yes, they come in and they're a mess, and you might have this preconceived bias about them. However, we need to understand where they're coming from and what has created this lifestyle for them and what they've been through, and how we cannot let them continue to fall through their cracks, and how we have to support them and give them the resources they need and the tools that they need to potentially and hopefully get out of this situation, and give them the best care that they deserve. Because you know what? Those incarcerated patients, those homeless patients, the frequent flyers, those are the ones who need our care the most. So we can't just sweep it under the rug like they're always here. Yes, they are. And you know what? We're going to see them for these things if we don't give them the best care that we can. So as a forensic nurse, it's important that all of us, sit down and be an ally for these patients with our providers. Now, I will say we're very lucky at Mercy. There's not many that feel that way. I hear it more from my colleagues in bigger cities. I had a patient that was a sexual assault patient also a while back, and I was working in the ER, and I happened to recognize, a name on the board, and she was there for attempted suicide. And so these studies and these statistics that I'm pulling off of the internet, this isn't a national thing. This is a local thing. I'm seeing it in our community. It's something that we need to be aware of and make sure that we are caring for these patients the best that we can. If you're a victim's advocate, whatever your role is in taking care of them, just be sure that you're giving them the time that they deserve to process through this. Let's see here. Let me get to the next slide. Looks like my computer is frozen. There we go. Child sex abuse. So this is another one that really gets to all of us. We do see it. We do see kiddos, 10 and under. A lot of times these kiddos are going to be sexually assaulted by a family member or someone that they trust, because at that age, stranger danger is a big thing. And they're not going to let somebody that they don't know in their intimate in their intimate circle. It's going to be somebody that they trust. So it's going to be a teacher, a coach, a parent, a family member, a step parent, a sibling. It's going to be somebody that they know, somebody that's going to easily manipulate them, and then convince them not to say anything to anyone. And so that's what we see a lot of delayed disclosures from these kiddos because they've been threatened, or maybe they're confused. They maybe think that this is normal until they start talking to peers, or maybe they get a little older and they realize it's not normal. So delayed disclosure is very common with our pediatric patients. And then also, whenever they're moving through the system, and for example, I have a case, this sexual assault happened on this 8-year-old girl. Well, she was 8 at the time, she's 10 now. So we've been going through the court process for 2 years now. Luckily, she hasn't had to get on the stand to testify. But the problem is, everybody wants to know about injury. Did I see injury? Was there injury? And for this particular girl, she falls into those statistics. Delayed disclosure. It was a year later that she actually told her parents that she was sexually assaulted. Based off of the history of what happened to her, I don't expect there to be any evidence of injury on her vagina because there wasn't direct penetration. So what's the problem with this is it's hard to prove in court, which is unfair to these victims. But we have to be sure that whenever these kiddos come to us, that we tell them, we believe you, we understand, and we're going to be here to help you, and make sure that they are now involved with some kind of therapy, some way to process through what they've had happen to them, and then maybe what they're going to endure if they end up going through the trial and the court process. It's not uncommon for kiddos to recant their story. So what that means is, say, for example, you have a kiddo who says, you know, I was at dad's this weekend and dad's touching me inappropriately. Mom and dad are separated. They're thinking about divorce. You know, and then what happens if they say that to their mom, and now their mom's like, you know, I'm going to file divorce, and the kiddo's watching all this unfold. Now the parents are for sure going to get a divorce. And now it's the kiddo's fault that she said something about dad touching her inappropriately. So what happens? Mom, it didn't happen. Dad didn't touch me that way, you know, because this kid is going to try maybe to keep that family together and feels like it's their fault for that happening. So we do see some recanting whenever it comes to child sex abuse. These statistics that you see now are going to be based on adult cases. So sexual assault in the United States, 1 in 6 women and 1 in 33 men. And of those, 1 in 4 women will report and 1 in 10 men will report. So, you know, even though the numbers are high, we're not really seeing all the numbers whenever they're, you know, whenever we're doing our statistics for forensic exams. So it's important that we do good community outreach and education to know that the hospital is a safe place for them to come. And if they were sexually assaulted, that they have reporting options that may not get the police involved. And that way we can make sure that they are in a system where they have resources, they don't have an unwanted pregnancy, they're not carrying an STI, and then maybe get into some therapy sessions. Most women know their offenders. Most of the time it's going to be their partner. And then sometimes it's also going to be an acquaintance. You'll see that that number for the acquaintance is higher in adults. And this is my theory. This is not something that I've read, but I think it's just because, you know, as adults, we're going out, maybe we're drinking socially, we let our guards down. That could be one reason. And let me just say that is okay if you want to go out and have drinks. That does not mean that you deserve to be sexually assaulted or assaulted in any way. But I think that with that chemical on board, you know, it kind of lets that guard down a little bit. Whereas with kiddos, you know, that's not one of the factors. And about 50% of men and women will be sexually assaulted by an acquaintance. And that's what we were saying. That's what I was just saying earlier. But this statistic is interesting to me because it says 45% are going to be American Indian. And that at Mercy, that statistic is actually a lot higher. 80% of our patient population that we care for at Mercy are Native. So it's important that we are doing good outreach and that everyone knows that this is a good, safe place for them to come for an exam. So I wouldn't be doing any of us justice if I didn't talk about the ACEs study. And I don't know if any of you are familiar with the ACEs study. If you're not, it's very interesting. And I sent some handouts to Kelsey for you to read. So ACEs, it stands for Adverse Childhood Experiences. They are potentially traumatic events that occur in childhood between the ages of 0 and 17. So in 1995, between 1995 and 1997, Kaiser Permanente conducted a study where they collected 17,000 confidential surveys from Southern California providers. You know, the patients submitted them to their providers. And in that study, there were a multitude of questions that they had to answer. So, you know, how old was your mom when she had you? What is your mother and father's education level? How many pregnancies have you had? How many miscarriages have you had? At what time were you pregnant? How old were you pregnant for this pregnancy and this pregnancy, if it was multiple pregnancies? Are you having intercourse with one person, or do you have intercourse with a multitude of people? What is your exercise history? How much did you exercise between these ages? How much did you exercise between these ages? What is your weight? Are you average? Are you obese? Are you overweight? Do you use drugs, alcohol? If you do, how much? How often? At what age did you start using them? Do your parents use drugs or alcohol? Have you witnessed them using drugs or alcohol as a kid? Do you have any mental health issues? Do your parents have any mental health issues? Have you been suicidal? Have you experienced verbal abuse, physical abuse, sexual abuse, any kind of witnessed abuse? Have you ever been neglected as a child? And then ask questions about what neglect means. Did you feel loved at home? And then have you witnessed your parents abusing one another? Do you know if your mother was sexually assaulted? Who lives in your home? It goes on and on and on, separation, divorce. And what they do is they add up what your answers are and they have a scoring process. And based off of that score, they assign you an ACEs score. If you have an ACEs score of 4 or higher, you can expect that it could potentially decrease your life expectancy by 20 years. And that is how you process the trauma as an adult. Do you have good coping skills? Did you receive therapy, or have you kicked that alcohol problem? Are you still abusing alcohol now? Are you making risky life decisions? So you can see that scale. I pulled that from the CDC, and what it all entails. So it's a very interesting study. And I feel like a lot of our patients have experienced traumatic childhood events. And I would be interested to see how many of them have an ACEs score of 4 or higher, because it starts as a pediatric patient and goes up through the lifespan. I want to share a little video with you. And it talks more about the ACEs study. So one of the last questions is what can we do to decrease the ACEs or combat the ACEs? And I have some handouts for you for that as well. So if you see here, this is a great visual tool. It talks about the different things that can happen, adverse childhood experiences. So you have an injury. Was there a traumatic brain injury, fractures or burns? Mental health issues, depression, anxiety, suicide, PTSD. Maternal health. So again, having unprotected sex at a young age, you can have unintentional pregnancies, which complicates things and could potentially have fetal death. Infectious disease. So risky behavior, unprotected sex. Maybe you don't have an unwanted pregnancy from that, but maybe you have an STI or HIV. Chronic diseases. So these are those people who've had a high ACEs score through their life, unable to process trauma and deal with trauma, and maybe don't have the best coping mechanisms. That can be reflective in chronic diseases, because all that trauma and all that stress releases cortisol, and then that increases inflammation, which increases your risk for cancer and diabetes. Risky behaviors, drugs and alcohol abuse, and unsafe sex, which go back to HIV and STDs and unwanted pregnancies. Having a mother or having a child as a young mother, that creates another slew of issues that could potentially happen. The mom is, desperate, doesn't have a good job, is trying to take care of her child. Maybe that child is then exposed to poverty, doesn't have access to food or basic needs, bouncing around between homes. Maybe there's a lot of partners coming in and out of the house and the child is, witnessing this. Mom is drinking more alcohol. The stepdad is sexually abusing her. CPS gets called in, the kid gets pulled out of the house. Once the kid gets pulled out of the house at a young age, maybe bounces between other foster cares, gets put back into a good system. But then, things start building up and building up and building up on this kiddo who's experienced so much. And then at one point, they give in, they succumb. No one's there to help them. The system is failing them. So what do? Risky behaviors. And then they become, it circles back to our frequent flyers in the ER. So how can we prevent adverse childhood experiences? Here's another video, also from the CDC. And these can all be found on the CDC. I think there's some great tools there.
This is my neighborhood. I grew up in this building. This is a great community now, but it's had its share of problems. When I was a kid, our community had high unemployment, a lack of resources for families, and lots of kids hanging out with no adult supervision. You might have heard about adverse childhood experiences, or ACEs. ACEs are traumatic events in childhood, increase risk for future problems, but they don't have to. The good news is that ACEs and their consequences can be prevented. Take me, for example. I was at risk for ACEs, and despite all the things that put me at risk, some pretty incredible people helped make sure that I wouldn't become another statistic. Come on, I'll show you around. That's Jackson. He's a cool kid. His dad left when he was 2, and his mom works 2 jobs. I hang out with him every Thursday night and help him with his homework. Sometimes we grab ice cream. It's fun. Plus, he has another adult role model to learn from and trust. That's Mr. Martino. When I was a kid, he let me help him at the store sometimes after school when my parents were working late. He did that for a bunch of us. My dad actually found his job as a mechanic because of Mr. Martino. This helped our family in so many ways. Paycheck, which eased his stress about paying rent and buying necessities like food and clothes, but he was also a lot nicer to me, my brother, and my mom once he started working a job that made him feel good about himself. When communities come together, they can do so much to prevent ACEs. Mr. Martino and other local business owners put together a series of career workshops to help people like my dad find work. My mom also got a job with a company that allowed her to work from home and spend more time with me and my brother. Mariana has just gotten out of a class about handling challenges of single parenting. The clinic offers free childcare so Mariana's daughter, Ella, can play while Mariana's in class. The class helps parents like Mariana develop positive parenting skills, not just for babies and toddlers, but for teenagers too. This is another way our community has come together to give families the resources they need, and just one more way to prevent ACEs. This was my school, Riverside Middle, right in the heart of town. These kids are here for a sponsored summer camp. This community-supported program helps families with affordable, quality childcare and helps kids get tutoring and learn life skills. When I was a kid, I spent a lot of time at this school all year long. There was one counselor, Miss Greer, who I remember more than anyone. She was a really good listener. Miss Greer helped me and my brother get involved in after-school activities like baseball and soccer. Our coaches were super nice and were mentors to us. Staying after school for practice kept us and a lot of other kids out of trouble. When schools help take responsibility for preventing ACEs, everybody wins. My life could have gone in a completely different direction. Studies show that ACEs can have long-term negative effects on kids' health and well-being that may last into adulthood and even continue in future generations. But by people and groups taking action, ACEs can be prevented. In fact, there are 5 known strategies that help stop ACEs before they even start. You can implement them in your own community, just like we did. How? By strengthening economic support for families, by changing social norms to support parents in positive parenting, providing quality care and education early in life, by enhancing parenting skills to promote healthy child development, and by intervening to lessen harms and prevent future risk. So, now you know my story, and you've seen the prevention strategies in my community that helped me beat the odds. I had healthy relationships with my family and friends. I learned how to take care of myself and make good choices. And today, I'm a mentor to other kids who need some extra help so they don't become an ACEs statistic. Safe, stable, and nurturing relationships and environments are essential to prevent child abuse and neglect and to assure that all kids reach their full potential. Are you thinking what I'm thinking? Banana split? You got it.
Thanks everyone for working with me through that. I apologize for the technical difficulties. This is the first time I've had a video on any of my PowerPoints, so that was a learning curve. I'm sorry if that was painful. But I felt like it was important for us to talk about ACEs study because it's so prevalent. And once you know more about it, you will definitely be able to point it out more and more and learn how to combat that and make sure that these patients and survivors that you're caring for are interacting with definitely know how to break those barriers. So I want to share another story with you all. This one was, so I was the SANE on call. I got a call in for a pediatric case, which every time we get those calls, our hearts just sink. The mom comes in with her daughter and she said, you know, I'm not 100% sure what happened, but you know, the problem is that it's a family member, it's close to home, and I have to keep my daughter safe and I have to believe what she's telling me. And so, you know, she tells me what her daughter said. And I tell her, you know, what we can offer her. Because it was, again, a delayed disclosure, we were unable to collect any evidence, and that's fine. It's almost something that we just assume it's going to be a delayed disclosure because not often do our pediatric patients come in right away. So the mother was recently, she's living on tribal land. They just moved back close to family. And, you know, it was a family member. It was another kiddo, a family member who was acting on her daughter. And so she wanted to stay traditional. She wanted to keep it within the family. And she spoke to the father of this boy and discussed the things that happened and what her daughter had told her. And then, you know, they discussed that, you know, they would keep them separate and they were going to come up with a plan so that this wouldn't happen again. But then the daughter said that it happened again. You know, it's hard with kids, you know, especially whenever you have working families and everybody's so close. This is an intermingling situation. The families are depending on each other to help them, you know, get to and from work, or maybe, you know, the kiddos coming over while the parents are both at work and nobody's there to supervise. And so it's very, very difficult to stop that from happening, right? So what happened is the daughter tells the mom, you know, it happened again. And so thank God the mother's husband supported her and said, yes, we need to report this, you know, which sometimes that isn't the case with family members. Sometimes there is, you know, concern that somebody's lying or there's not that family support. But this mom had no idea what she could do, but all she knew is that she had to protect her daughter. And she came in and she was, you know, full of shame because of what happened, but then also scared because she knew that she was potentially going to break up the family and she didn't know how to navigate that. And she was scared, you know, that, you know, what she was going to go home to after being there. And it's just an array of emotions. And the one thing that I could just continue to tell this mother is, you are brave, and you are so brave to bring your daughter in against, you know, what you may have to endure once you go home. And you never know if you could be inspiring to other women in your community to come forward and talk about that. But what you're doing is you're stopping this cycle. You're protecting your daughter. You're doing the best that you can. And I was so proud of her. And I told her that, how proud I was of her and that she did the right thing, even though for her, it didn't necessarily feel like the right thing at the time. And so we continued to talk about resources and how to get her through. She had an advocate with her who was incredible. It was just such a touching story, but also I couldn't help but to think of these ACEs scores, right? So we're talking about this young girl who was molested by a family member. Let's talk about this family member. You know, let's talk about what this little kiddo that's doing this to her, what he's been through. So as she's telling me, you know, like he has also experienced some adverse childhood experiences as well that were traumatic to him. He doesn't have a lot of family support at home. You know, the dad is an alcoholic. He was sexually abusing his stepsisters. He's experienced parental death at a young age. He has also witnessed his dad in many unhealthy relationships. No one's there to supervise him while everybody's at work. He's no longer going to school. And I mean, it just goes on and on and on. So we can not only look at our victims that come forward, but we need to start looking at these perpetrators and what they're going through. And this kiddo definitely is falling through the cracks as well, which is hard. You know, that's not something I'm going to talk to the parents about that's presenting there. I mean, a little bit maybe, but I would hope that somebody is putting an eye on this other child and trying to get him the help he needs also. What are the financial impacts of our survivors? This is a very interesting pie chart that I created based off of the cost in crimes in billions. And if you see the blue there, that's the cost in rapes compared to assault in yellow, murder in red, and drunk driving, including fatalities, in green. Now, women or men who have experienced sexual abuse in their lifetime will have additional healthcare costs down through their lifespan because of all of those risk factors that come up to light, that, you know, chronic disease, depression, the things that we talked about before. So what can we do as providers? We need to stop victim blaming. We can't say she wanted it. She shouldn't have dressed that way. She shouldn't have drank that much. She shouldn't have acted that way. She shouldn't have flirted with him early on in the night. It wasn't really rape because she didn't fight back. As we talked about the neurobiology of trauma, the fight, flight, or freeze response is real. Mostly the freeze. People cannot believe that they did not fight back because they think in their head, I'm going to fight back. But whenever they're flooded with all these emotions and hormones, sometimes they just freeze for safety. I'm wrapping this up. I know we're at 1 o'clock. If you need to take off, I understand, and I'm sorry for the technical difficulties. So here I'd like to just show a few different scenarios. If you see that young lady in the black dress, her name is Daisy. She's a survivor of sexual assault. She crawled into the window of a football player's home in her hometown. She was a cheerleader. She drank a lot of alcohol. She got really drunk, and she was sexually assaulted basically when she was passed out. What does the community say? This was a small Midwestern football loving town. She shouldn't have crawled into that window. She should have taken responsibility of her own actions, and no one believed her. So what ended up happening? She had to leave her hometown and everything she knew. And if you watch her lifespan, more and more tattoos, more and more risky behavior, in and out of mental health facilities, dealing with her own mental health, but she was a pioneer for women who've gone through sexual assault in their time. But eventually Daisy took her own life. You can look up her story on Netflix. This other young man that you see here in the corner, he's not a victim, he's the perpetrator. This is Brock Turner. He was the Ivy League swimmer. He was on the varsity swim team. He sexually assaulted a woman behind a dumpster at Stanford, and she was left there. And basically she was slotted in the media as the unconscious, intoxicated woman who had no identity but that. USA Gymnastics, we're talking about these young athletes who have been sexually molested and assaulted throughout their entire athletic career by Larry Nassar. He was the doctor for the USA Gymnastics team. That is a Netflix, it's on Netflix also, and it's called Athlete-A. It's a documentary. So again, let's start by believing. These are some quick statistics about how many actually go to trial, how many are prosecuted, how many are incarcerated. And that is the end of my presentation. Again, guys, I am sorry for the delay and we are behind on time, but if anyone has any questions, I can open it up right now to questions if you have some.